And I'm really pleased to say that the presentation that we will be hearing today has been published now, basically came out today, so really hot off the press, as an article, which we'll be sharing in the chat for those of you who want to go into greater depth into either the methods or the content. So without further ado, Peter, I'm handing over to you, and yeah, take your time to share the slides. Thank you.
I've been interested in refugee mental health for a while now, but I was going to begin this by talking more about how I came to be interested in this particular topic in the first place, and then the whole process of this research project, and where we got to in the results of our study. So my interest started with the role of place in mental health generally, particularly more severe mental disorders. And by that, I mean disorders like schizophrenia and bipolar disorder, or those that come under the general umbrella term of psychosis. I think one of the big issues for me and a lot of people over the past few decades is that originally a lot of these disorders were seen as universal and unrelated to any kind of social factor. They were just a biological fact, and it's become, over the past couple of decades, 2 or 3 decades, increasingly obvious that there are very strong social patterns in psychosis, particularly. I'll talk about other mental disorders as we go on, but particularly psychotic disorders. There was a big review a few years ago that found that after genetic propensity, the 2 factors most strongly associated with psychosis were membership of a minority ethnic or migrant group, whether first or second generation, and also being brought up in an urban environment. And those 2 things were the most consistent and had the strongest relation with risk of psychotic disorder. It's really important to stress that when we look at membership of a minority ethnic group, we're not looking at ethnicity in itself, whatever that means as a category. If you look at different groups in their country of origin, if you go to Africa, and people have done these studies, or you go to Jamaica and you look at the rates of psychotic disorders, they're no different from the rates of psychosis among the majority white population in the UK. What seems to make a difference is migration. It's something about the fact of migration. And it's not just migration itself, it's something that then persists into the second generation and beyond. Similarly, with urbanicity, you've got, I think there was a meta-analysis a few years ago. I think recent results are very similar, where you've got more than double the risk of schizophrenia if you grow up in a city as opposed to a rural neighbourhood. The reason why I'm saying all of this is that what links these 2 predominant risk factors for psychosis is that they're about place. They're about the role of place, whether it's living in an urban neighbourhood or being a migrant. These make a hugely important difference to what was previously seen as something purely a neurological, biological phenomenon. So I started looking at this. One of the there were a lot of studies about 10, 20 years ago showing high rates of psychosis in the different Black and ethnic minority groups in Southeast London. And one of the things that people were seeing was that it depended on what kind of neighbourhood you lived in. And in particular, this ethnic density effect. By that, I mean that if you were, say, from the Caribbean and you lived in an area with more people who are also from the Caribbean, first, second generation, you had a lower risk of psychosis. So there's something protective about that. So I did a study looking at using GP data to look at rates of psychosis and found, I'm not sure it's obvious from these maps, but the rates of psychosis were actually lower than you'd expect given the deprivation levels of the kind of neighbourhoods that had the greatest concentration of people from the Caribbean. So it was very obvious from that study there was some kind of ethnic density effect. The problem with that kind of study is that this was cross-sectional only. I was just looking at one point in time. Any study of place is always going to be limited by how much you can distinguish between people moving to a particular kind of area because of their health, and then the effect of living in that kind of area on people's health in the first place. So essentially, is it the neighbourhood that makes people ill, or is it people being ill that determines what kind of neighbourhood they live in? It's a huge problem in any of this kind of research, and you see it in a lot of the studies now looking at, say, green spaces have this fundamental problem. How do you distinguish people living in a certain kind of neighbourhood because of their health? So what I then did was I went to Denmark, which has the huge advantage, as with other Scandinavian countries, that data for the entire population is made available to researchers. So essentially, you are able to look at all the administrative data. So that's health records, employment data, education data, income, tax records, everything. It's all anonymized, and there's a huge amount of trouble taken to make sure that no identifying information is allowed out. But it then has this huge benefit that you can look at a lot of, particularly, well, in this case, epidemiological questions. So we're looking at a health outcome, looking at the entire population and following them over time. So what I was interested in doing was looking at the effect of living in a particular kind of place on subsequent incidents of psychotic illness. So disorders like schizophrenia and bipolar disorder. So I took everybody living in Denmark, followed them up from where they were age 15, essentially where their parents lived, and to then see what was the relation between the kind of place they were living when they were 15 and their subsequent incidents of severe mental disorder. So this essentially shows you the kind of timeline of each individual in the study. So we follow people over time. What I found was, just as in the UK study in Southeast London, there was this huge ethnic density effect. By huge, I mean in relative terms. So there was about a 30% increase in risk of psychosis for those in the most versus the least ethnically dense neighborhoods. So, and these maps, I'm not sure, it's probably not completely obvious, but if you look at density of, say, Africans, Typically, those would be in the more deprived areas of Copenhagen in these maps. So you'd expect higher rate of psychosis. And in fact, you actually have a lower rate or a lower prevalence in this case. So that was very clear. So I looked at other aspects of neighbourhood as well. I looked at urbanicity and different generation effects. But one of the things that I noticed when I was doing this Danish study was that there were a few areas with very high concentrations of migrants in Denmark. So I was curious about this. I mean, one of the advantages of when I did this project was that I spent a long time in Denmark, so I could talk to Danes about the data I was looking at. They had quite a well-resourced scheme for working with outside researchers. So I talked to the people in the research group in Aarhus and asked them, in particular, this very dark red area with a very high proportion of people from the Middle East. So I asked them about what is this area? It looks like a sort of ghetto. And the people I spoke to shook their heads and said, "Oh, yeah, no, we know about that. That's Gellerup. That's a suburb of Aarhus that had historically been a major problem to people in Denmark because they saw it as essentially, they used the term ghetto. And they saw that this was a problem. Gellerup was seen as a problem. I think since then, a lot of what I've read about Gellerup is that it's a lot more complex than that. And actually people in Gellerup don't necessarily see it as a problem. And the history ever since of Danish policy, though, has tended to be that they see these areas as problematic, and they've done everything they can to disperse the population. Anyway, that's a long aside. I was interested in Gellerup and this very high concentration, and also it was a lower rate of there was a lower rate of psychosis despite the social problems that were being flagged up at the time. And the important thing about Gellerup is that there's a largely refugee population. So that got me interested in the particular situation of refugees and severe mental illness. So here's a picture. The first thing I did was look up Gellerup on Google Maps, it's very far from the sort of stereotypical image that we get of Denmark, of the bicycles and Copenhagen, and a lot more like the kind of picture we get in more deprived parts of London or other cities in the UK. So the other, around about the same time, there was also an increasing interest in refugees as a special case of migrant populations having a higher risk of severe mental disorder. And there have been since quite a few studies. There was a review a few years ago that found roughly 43%, 1.43 times increased risk of psychosis among refugees compared to other kinds of migrants. So migrants are already at increased risk of psychosis, but refugees are at an even higher risk. So you've got a population that are uniquely vulnerable to these kind of life-changing psychotic disorders. There seemed to be a consensus in the research that it's not just what refugees are fleeing from that's relevant, it's also the social context of the place they're going to. So it's not a given that refugees will necessarily come with mental health problems. It all depends what kind of social context they're received into. But at the time, and I think it's still the case, when I started this study, there was very little research about the kind of neighbourhoods that refugees were living in, and the role of neighbourhood. To me, one of the important things about neighbourhoods, and particularly refugees, is that refugees are uniquely put in a position where the place where they end up living is typically influenced by government policy. So in the UK, we have a dispersal policy. In other parts of Europe, they have a more strictly, we've got a fairly loose dispersal policy. In other parts of Europe, it's a lot more prescriptive. What this means is, if you see neighbourhood as an exposure that could potentially increase people's risk or decrease people's risk of mental illness, this is a potentially modifiable exposure. It's something that we have some control over, which is important. We don't normally. So this inspired the current project. So I was interested in all the studies I've done. I've tried to combine large-scale statistical analysis with more in-depth qualitative studies. I'll talk a bit more about that in a moment. But this is very much a mixed method study about the role of place in the mental health of refugees. So Denmark is an example that particularly lent itself to this topic. So it's just as a methodological aside, so mostly what I'm talking about now is the quantitative work that we did. To me, and I think for most people that do this kind of research, this kind of large-scale quantitative study has the benefit that you can potentially reveal broad patterns in the social world. So essentially, and to illustrate this, this is an aerial view of Venice that I found on the internet. You have a bird's eye view of the world. I think it's important to be clear that this is just one kind of knowledge about the social world. So it's a particular perspective. In a lot of ways, it's an unusual perspective, but it has the benefit that you can potentially look at everybody, whereas survey approaches, more qualitative, in-depth research is often very restricted to who you can access. And also because you're looking at the whole population, it potentially has a direct policy relevance. The disadvantages, as I'll say a bit more, I'll try not to be too negative, but it's often very difficult to access this kind of data. That's why I had to go to Denmark. It typically lacks detail. We're reliant on official classifications, or in this case, psychiatric diagnoses, and with all their limitations. So you're always reading between the lines. So a lot of this depends on how you interpret the categories that are being used. And typically we're using proxy measures. In this particular study, at the time that I looked at refugees in Denmark, there was no official recording of refugee status. So we're reliant on country of origin and date of migration to establish whether or not someone was a refugee. And even now in the UK, we rely on proxy measures often when we use quantitative data to look at refugees. So there are advantages, huge advantages, but also these important disadvantages to bear in mind. So I'll talk a little bit more about the methods. Maybe worth flagging up. We're going to have a break in about 5-10 minutes, at which point you can ask some questions about how we did the study, and I can stop just presenting. But so what had gone before. We did a scoping study. So Gunther Zermenson's, my colleague, looked at all the previous studies that addressed this topic and found none had actually followed refugees over time on any large scale. So there were no big quantitative studies over time. The nearest we could find in the UK was something called the Survey of New Refugees, which was an exercise conducted a long time ago now, in between 2005 and 2007. They looked at everyone granted asylum at that time, but unfortunately retained no data about where they were living. So that was a huge missed opportunity. Since then, all the other studies have been on fairly small scale. I mean, hugely valuable all the same, but still on a small scale. I then discovered there were actually some good precedents for looking at refugee outcomes using Scandinavian registered data, which I'll talk about in a moment. Actually, this is there's another review looking at refugee mental health studies. It's a slightly different point. I don't know if it's obvious looking at this slide, but if you look at the smaller studies, so as you go down the chart, you'll see that the prevalence of mental disorder is much higher in the smaller studies. So there's a potential flaw in these kind of small scale studies. So that was another thing that inspired me. And okay, I was going to talk about, so there's a very useful precedent for this kind of study, which I discovered through a colleague in Aarhus, the team that I was working with, who'd spent a lot of time developing this model based on the fact that refugees assigned housing in Denmark were being assigned a place to live with no actual face-to-face contact with housing officials. Essentially, all the housing officials knew about the refugees that applied when they arrived in Denmark was just the answers to a very simple questionnaire. And on that basis, they were assigned housing. So what my colleague, Anna Pildam, did was that she analysed their outcomes. In her, Anna is an economist, so she was interested in things like employment, and she looked at crime rates and various other outcomes. She simply adjusted for what was in the questionnaire when refugees arrived. Having done that, she could then say that the neighbourhood they were assigned to had no bearing on the characteristics of the refugees themselves. So whereas normally when we look at place, it's very hard to untangle, if we're looking at, say, the difference between people in London and people in Newcastle, people will move to London for very particular reasons based on their own personal circumstances. People will move to Newcastle for other reasons. But it's impossible to untangle what's happening because you live in London and because you live in Newcastle from your own personal characteristics, because that's determined why you live in that particular place. But in this almost unique situation, you can untangle the effect of the personal characteristics of refugees from the place where they end up living. So that's essentially what makes it what we call a quasi-experimental design. It's not entirely experimental because we didn't actually randomly assign people, but in effect, that's what's happened. As an aside, the only other attempt to do this, or natural experiment to use them, the phrase that is often used to describe this, that I've been able to find, is something called the Moving to Opportunity study in the US, which was a big study where people were randomly given the opportunity to take vouchers to go and live in a less deprived area. And those people who received the vouchers, who were randomly lucky enough to get the vouchers, were then followed over time to see what was the effect of being able to afford to live in a more upmarket area. They found that there were mental health benefits to living in a less deprived neighbourhood. So this is the Moving to Opportunity study. It's the only other example. So in Denmark, we had the opportunity to do that. So yeah, I've put up this. Anna Pildamm had various studies looking at employment, youth crime, and other outcomes using this design. We looked at all refugees. In our study, our outcomes were various mental disorders. So it wasn't just psychosis. We also looked at mood disorders, stress, anxiety disorders, and PTSD. The area exposure was where people were first assigned. Essentially, it's the equivalent of an intention to treat design, which, if any epidemiologists among you will know, means that you ignore anybody that doesn't have the treatment. So if people move on, we ignore that. We're only interested in the neighbourhood where somebody is first assigned. And we looked at different neighbourhood predictors. We looked at ethnic density that I mentioned before, also urbanicity, and also area deprivation levels. And we did a test. We compared people's pre-migration education levels to check whether or not they influenced the kind of neighbourhood people ended up living in. And just as a spoiler, there was no relation. So essentially our design, as far as we were concerned, meant that people were being randomly assigned. There was no relation between their characteristics and where they ended up. So I think that's a good natural break. I mean, if anybody's got any, maybe you haven't, but if anyone's got a methods question before I say any more about the study, now is a good time, or maybe it's all been completely straightforward.
So Peter, I captured a couple of questions in the chat, and there's also one by Ben. Should I just read them out to you?
I haven't looked at the chat.
Great. So the first one is by Laia, who asks, it would be great to know what's understood about an urban environment in this context. Is it to do with social isolation, economic mobility, housing, poverty?
That's a really big question. And I mean, not one that I was able to answer in this particular study. Essentially, we control for the effect of urbanicity. So I didn't particularly concentrate on that. There's been other research looking at aspects of urban environments that might be relevant. And my understanding is that it's typically the conclusion is that it's an accumulation of all those things. So it's the accumulated stresses of urban living. But I'm not sure if that's a completely satisfactory answer. But it wasn't the focus of this study.
Great. Then I'm moving to Kit. Kit had a first question in the chat, and now a methods question. So Kit, I hope you don't mind if I move to your questions in the chat now, because they relate to methods. These are there any twin studies in this field? And could you control for number, severity of life events, such as torture, sexual violence, durations of mode of travel, etc.?
Yeah, I'm not aware of any twin studies in this. I think that would be very difficult, just given the numbers. I mean, it'd be extremely difficult. As for pre-migration trauma, it's the fact that that's not something that was known to housing officials means that effectively that's factored out. So it shouldn't have influenced where people end up living. So if we treat this as effectively random, then in some ways we've controlled for that. The other issue about pre-migration trauma is that, well, in this study, the focus is all on the post-migration environment. And part of the justification for that is that that's something we can do something about. So we can't do anything about the pre-migration trauma. That's already happened. What we can do is make sure that the social environment that people are moving into is going to be as conducive as possible for their mental health. So this hasn't really focused on trauma at all.
Thank you. And then there's Ben, who asks, do you see an ethical dilemma with randomly assigning housing in better neighborhoods?
Yes. So yeah, there would be. And so this it's a quasi-random study. So we don't actually randomly assign people. It's a byproduct of, and this is a particular period of time in Denmark where people were effectively being randomly assigned housing because of the way that the housing policy worked. So they didn't set out to do this to help researchers to have a nice epidemiological design. We're just taking advantage of this. So no, I don't think it would be ethical.
One more question and then moving on. So again, from Kid, could you measure degree of integration within could you measure degree of integration within acceptance by the new neighborhood?
I think that would be fantastic, but wouldn't be possible even with the kind of data we can access in Denmark. I think that would require a survey approach. So that's where we come up against the limitations of this kind of very large scale study. But yeah, that could be hugely important.
Great, thank you so much. Shall we move on with the presentation?
Okay, so all right,
thank you.
I'll resume. I mean, there'll be opportunity for more questions at the end. So I was also going to say, I mean, a little bit about the research process. There's a tendency when presenting this kind of research to make everything look very neat. But I think it's useful, especially given we've got time, to give you a little bit of an insight into the messy world of quantitative data analysis. I applied for MRC funding, Medical Research Council funding, in 2017, didn't get accepted, but was asked to reapply. A year later, they agreed to fund this, which was fantastic news. The study actually began about 6 months after that. We then had the combined catastrophe, for a lot of people, of Brexit, but then with also the added problem of the new GDPR rules that meant access to data, particularly international data, was problematic. And the access to the Danish data that I was using, we were no longer considered a trusted partner. So I essentially lost the access that I originally had to Danish population data. So I then had a long process of negotiating a new access agreement. Finally, through a colleague at Copenhagen University, I was originally at Aarhus, managed to get a new access. The problem with that was that they didn't have anybody to put together the data for me. So there was then a very long process of assembling all the data myself, which was very lengthy and complicated because it's all in Danish. So I spent a lot of time looking at Google Translate and actually started learning Danish at one point during lockdown in order to put this together. So it's taken a very long time. Eventually, round about a year ago, I started to analyze this, wrote the paper, and it's finally got published. So it's been a long process, but hopefully worthwhile. So with all that in mind, we've got these results. What the first thing that I did was just very straightforward, look at incidence of mental disorder among refugees compared to the rest of the population. And I found that overall refugees had a 1.5 times higher incidence of any psychiatric disorder. They had double the rate of what we call non-affective psychosis. That means schizophrenia and schizophrenia type disorders. 1.2 times depression, mood disorders, just over double the rate of stress anxiety disorders, a hugely increased rate of PTSD, but I think a lot of that is to do with this diagnosis being reserved largely for refugees. So we then looked at using this quasi-experimental design. We looked at a couple of area level factors. We looked at the deprivation rates and also the density of the population, so how urban the population was. And neither made much difference to the rates of any of the mental disorders that we looked at, which was a surprise because other studies have found very clear, particularly for population density, links with subsequent mental disorder. What did seem to be important was the role of neighbourhood ethnic density. We found particularly the proportion of people from the same country as the individual refugees we looked at, to the extent that we divided up neighbourhoods into what we call quartiles. So the most dense quartiles, the most dense quarter of our population of neighbourhoods versus the least dense quarter. And we found a 25% increase in psychosis risk for those who were in the least dense quartile. That is, those who were living with the fewest from their own country of origin. So this chart maybe needs some talking through. This shows, each line shows a different mental disorder. And if you look, the scale shows 1 is living in the lowest density neighborhood. So this is, if you're, say, African, this would be the neighborhood with the least number of Africans living in that area. 4 is the highest density. So that would be the neighborhood with the greatest proportion of people from Africa. And you can see there's a clear gradient, but this is most obvious for non-affective psychosis, that is schizophrenia type disorders, and also PTSD. The dotted lines show essentially the confidence interval. So that's our level of uncertainty. So what we can be sure about is this doesn't cross 1. So it means it's more likely that you will develop a non-affective psychosis, and we can be statistically confident that that is not spurious if you're in a low density area compared to high density. So there's something about living in a neighborhood with people from the same country of origin. This was less obvious for other mood disorders, and we found hardly any effect for stress disorders, which to me was interesting. It's something about, potentially it's to do with severity. Psychotic disorders are likely to be a lot more severe and long-lasting. We've also PTSD, which was a surprise, but that seemed to be particularly influenced by the number of co-nationals. To give some context, and again, this needs some talking through, but exactly what does it mean to be in a low versus high density neighborhood? So in the Danish context, being in a low density neighborhood in terms of your country of origin. Essentially means if you look at a neighbourhood, in the neighbourhood units we're using here amount to roughly 2,500 people. So essentially there would be nobody else. So if you're a migrant a refugee from Syria, there would be no one else from Syria among the 2,500 people in your neighbourhood. If you look at the highest density area, you've still got a very low number. So in this case, you've got 3% of co-nationals. So that would amount to, in numerical terms, about 70 out of 2,500. So you've got a very small community, but that would be the highest. So it's worth bearing that in mind. And I think this is a lot more relatively quite different from the UK, where you may have much higher concentrations of co-nationals in the higher density areas than you get in Denmark. So we also, when we looked at proportion of co-nationals, we adjusted for neighbourhood deprivation and population density. And this meant that actually we saw a greater risk of psychosis when we adjusted for those two things. And I think that was because they're working in the opposite direction. So the more ethnically dense areas are more deprived. Once you adjust for deprivation, you get an increased density effect. So we didn't just look at density of co-nationals. We also looked at density of any kind of refugee. One of the things that I thought could potentially be going on is that you've got more services aimed at refugees, so people are better looked after. But actually, just living in an area with lots of refugees didn't necessarily make as much difference. There's a similar effect, but it's not as strong as when you look at density of co-nationals. The other issue, I thought potentially, maybe it's just density of migrants, just living in an area with lots of migrants. Perhaps people are less prejudice against migrants generally. There's less chance of discrimination. But actually, density of migrants overall made no difference whatsoever. There's really, really no effect. These are essentially random. We also looked at density of what the Danish official classification is non-Western migrants, which I can go into detail if you're interested, but that made no difference either. So looking at the wider literature, I mean, there's quite a big literature on dispersal policies. So essentially, this is the result of a dispersal policy. People were sent to far-flung parts of the country. Typically, this means that people will then move to be nearer their own people from their own country of origin. So that makes sense. It fits with that. It's also worth saying a little bit about the other part of the research that we did. So we had a qualitative study in the UK, which was intended to get around a lot of the problems with large-scale quantitative research that I talked about before. So in the UK study, we just looked at Somali refugees. And that was led by Günther Zalmansons, who's published on this just this year. And Günther spent a lot of time concentrating on the Somali community in London and Bristol, and found that a lot of community networks themselves had a lot of bearing on people's mental health, particularly the role that the Somali diaspora had in terms of increasing people's sense of agency, ability to create their own community, set up their own businesses, So it's worth looking at Gunther's paper just to get a bit more of a sense of what's actually going on behind these broader trends that we're showing with the Danish data. It's worth also bearing in mind, we have this broad sweep analysis. Okay, density of co-nationals is potentially protective. It's worth bearing in mind that this is an average. If we look at a population level, we see this. At an individual level, it's not always the case. So when Gunther's interviewed people and asked them about their own community, there were instances where some people were actually very keen to get away from people from their own ethnic group. For example, there was maybe more perceived stigma. So it's potentially very complex. What though I think we were able to do with this study is identify some very broad trends that are potentially important for policy. So what we're doing now, I've got a researcher who's doing a similar analysis, but on a much smaller scale using data in Southeast London. Unfortunately, we have nothing like the equivalent of the Danish register data here. I'm interested in looking at other outcomes for refugees using the Danish data. Unfortunately, the MRC funding ran out quite a while ago, so we're now applying, along with Hannah Kienzler and others, we're applying for UK funding to do a much larger UK study addressing these questions. So looking at the role of place in refugee mental health. And there have been a lot of papers on this. We had 3 papers specifically about refugee mental health and place. And then I've listed a few papers looking at these various issues about migrants in general.